maybe we could talk a little bit about what we do in hospital and how we help within teams within the hospital. So I talked a little bit earlier about how I'm very specialised now, and I work in inherited metabolic disorders, so I don't work so much on the wards anymore, but you two still, well, you work on the wards.
Yes. Yep, not long ago. So I generally, most of my time is working on the neuro ward. That's where I've been this morning. I see a lot of patients that have head injuries, spinal injuries as well. Causes are sometimes trauma, so the QE accepts a lot of big trauma patients. So head injuries, car accidents, see lots of different ages. So
and we have the defence military.
Yeah, we accept military patients here as well, so we see them. So whether it's just someone that's had a really severe sort of brain bleed and had to have surgery, so I work on the neurosurgical wards, so that's one of the things, but the other things, as I said, is severe head trauma or spinal trauma, which means trauma being a severe incident or an accident, and they'll come in. A lot of them, because of the brain functioning, they might not be able to have a safe swallow, so I work really close with speech and language therapists. We work really closely with them. They'll tell us whether or not someone can swallow, and then we do artificial feeding. So
I've got
props here. I've got props here.
Bring it to view.
There we go.
And this one here.
Yeah, so the tubes. So this is a nasogastric feeding tube. So naso, because the tip of this goes into your nose, and then the end would end up in the tip of your, into your stomach. So it's to deliver some feed through it. So I think we've got some feed hanging just there. So we've got a range of feeds there. And we prescribe them depending on the patient. So some have fibrin, some don't. We also have some formulations for people that don't absorb the food very well. So we also have that. So if they have any gut problems, and there's quite a few options. So this end connects to what we call a giving set, which is this lovely thing here. So there's two ends to it. One attaches to the patient's nose, and one attaches straight into the feed bag. And this is the pump that it gets delivered in. So that's generally what it looks like here. So we've got the cassette thing here. Usually we have nurses that come and train their patients on tubes before they go home. So that's really handy. So we work really close with the companies. But yeah, this is generally how they hang. So in the hospital, they're always on the drip stand. These are what patients take home with them. So some of my patients will have long-term feeding tubes. So this is one that goes straight into the stomach from the outside, so it'll be here. So we train them up, and they might go home if they need long-term feeding.
How do they place these ones that go straight into the stomach?
They go to endoscopy, so it gets guided with the scope, so similar to how this would go in, but obviously the bigger tube. It gets guided through, and then so you're kind of pulling it through this way without the attachments, and then it comes out the other end. So this is your tummy here, and then this bumper helps it to stay in your stomach. So then obviously if there's any pulling or anything, then it shouldn't come out unless you have really hard, which is no, don't really want to know that. But yeah, this plate goes against the belly, and then this attaches to the giving set. So yeah, that's generally, some patients can look after it themselves, but not in my patient group, unfortunately, because of their brain function. But there are some patients, like cancer patients. I think we're seeing some posts about our upper GI dietitians, so they get trained themselves on how to use these, because of cancers and things like that. Or their family get trained, or they go to sort of nursing homes, or a lot of ours go to rehab units. So yeah, that's what we do. So I regularly see these artificially fed patients. I don't tell people how to lose weight. That's not my job. It hasn't been my job for a while.
Great.
What about you, Jem?
So, like I said before, so I'm essentially the floater of the department, which has been great. I've had not how it meant. Which basically means that I cover things like annual leave, sickness, maternity leave, or just unplanned leave, to make sure that certain teams do have adequate cover. So at the moment I am covering Kings Norton and Worcester dialysis units. So you may not necessarily think a dietitian is needed when you have patients who are on dialysis. However, actually thinking about their nutritional needs, patients they still can be malnourished, more than anything else, we're kind of thinking about interpreting their blood results and kind of the correct dietary information that we might be giving. So thinking about their monthly bloods and what that's kind of telling us, whether their potassium is high, their phosphate is high, their calcium is low, their weight is coming off, they're coming off dialysis quite heavier than they should be, might mean that they've got too much fluid on or they're drinking too much fluid. So all these different factors will be covered at the dialysis unit by a specialist renal dietitian.
So what happens if someone's potassium is too high? What foods have got potassium in?
So generally, everybody knows that bananas have got lots of potassium in there. Certain ones that you may not know are things like coffee, tomatoes, chocolate, unfortunately. There's quite a few different foods that do have a lot of potassium in, and sometimes it's the way that you cook them as well. So all vegetables have got potassium in them, but if you boil them, you let that potassium out into the water, and then that vegetable is much better for you to eat, lower in potassium, once you kind of tip that water away. So kind of helpful tips and hints and things that we kind of give to our patients. Oranges are high in potassium, but satsumas are low in potassium. Don't ask me how, I don't know. It's just
I actually didn't know that one, so it goes to show if you don't work in a certain area for a while.
Yeah, wow. Then you may not know, so that's a little loophole, which is good. And in terms of phosphate, again as well, so phosphate is there to kind of help regulate your bone health. So obviously we need it to be at a certain level. If it's too high, then we can find it's quite damaging for your bones. So patients can go on a lower phosphate diet. Unfortunately, some of the foods that are quite high in phosphate are generally your protein sources as well, so things like meats, cheese, dairy, eggs. So we tend to help them with the low phosphate diet, but more than anything we usually put them on binders which help bind their phosphate in their food, so that it doesn't really get absorbed into their blood.
And binders are tablets, are they?
Yes, sorry. Yeah, so phosphate binders, which are small medications, well actually quite large medications, large tablets that they need to take with their meals, often 3 times a day, sometimes with snacks as well, depending on their phosphate levels, more than anything else. And then I also help cover the general medicine wards, which is like an umbrella term for respiratory, elderly care, vascular, diabetes. Anything else that I'm missing?
No,
Lovely
you've got the main one.
Nula's on the side.
Nula's on the side,
Dietitians on the side.
True.
I work with people with inherited metabolic disorders, so they're very rare disorders where the metabolism is not working properly. So the fat metabolism might not be working, or the carbohydrate or the protein, and therefore the diet needs to be, if the fat's not working properly, then they might need to be on a low fat diet, or if their protein or they can't break down amino acids properly, then they'll need to be on a low protein diet. So it's very specialised, and there's not many centres in the country that cover it. We cover the whole West Midlands and further beyond, but